So we're going to take a little bit deeper dive in that sort of understanding addiction and its underlying causes. Um, so tonight, we're going to discuss the overlap of those three conditions, and I am going to abbreviate. So as we go through these slides, just kind of level set that schizophrenia is the SCZ, BD is bipolar, and SUD stands for substance use disorders. We'll also talk a little bit about the barriers to care and how to optimize outcomes from treatment, but also how to optimize outcomes for caregivers that are trying to help loved ones with mental illness. And then I'm going to work in the New Mexico 5 Actions program as well, specific to substance use disorders. Before we jump in, I want to share with you one of my favorite poems that's titled The Way It Is. William Stafford wrote this about 3 weeks before he passed, and he's a poet that actually lives kind of local in my neighborhood. But what he says is, there's a thread you follow. It goes among things that change, but it doesn't change. People wonder about what you are pursuing. You have to explain about the thread, but it is hard for others to see. While you hold it, you can't get lost. Tragedies happen. People get hurt or die, and you suffer and get old. Nothing you do can stop time's unfolding. You don't ever let go of the thread. I love this because I know in my own life there has been lots of turbulence, uncertainty. Absolutely, there's been challenges, tragedies. Close friends of mine have died in the last couple of years. And I think holding on to a thread, I think it's different for everybody. We all have to find that thread, that thing that doesn't change when everything else in our life seems like it's constantly changing and there's chaos. So I'll kind of leave it at that. We can come back to it if you have questions, but the idea is that we are sort of entering into challenging territory, and having kind of a rudder can be really helpful. So when we think about the overlap of these three different symptoms, schizophrenia, bipolar, and substance use, you guys have probably seen this graphic on the right. I think it's been in prior presentations, and it's just showing the 5 symptom categories. And you can see that in general, we have the positive symptoms, which is basically the delusions and hallucinations from psychosis. We have the negative symptoms, the things that should be there but aren't, like lack of motivation, social withdrawal. We have the cognitive impairment piece, alterations in memory, attention. And then we have the depression and the mania. And you can see there, these are 3 different patients. So again, the red lines kind of move around a little bit. I wanted to just make one comment, though, on the cognitive impairment piece. That is an area that there's been a lot of work on lately. I think one of the past presenters mentioned that in the last 50 years, we haven't really had a lot of new medications, but we actually do have a new medication that was recently approved by the FDA. It was going by the name CarXT, and now its brand name is Cobenfy. It's a muscarinic, which is different. It operates on dopamine, but not directly. So it has a different profile for side effects. I just wanted to kind of point that out because a lot of people are talking about this. It has some kind of impact on the cognitive impairment piece. But this is sort of the overlap between these two. Schizoaffective is sort of, these are all on a spectrum. And when we look at the overlap with substance use disorders, the bar graph on the left is the latest data from the National Survey on Drug Use and Health. And when you look at any mental illness, you can see that it's pretty high. Those are the dark blue bars. But when we think about serious mental illness, you can see that for illicit drugs, it's almost 52%. And when we break out the different illicit drugs, which I've done over there on the right, you can see by far marijuana is number 1, right? It's almost 47%. And you can see that cocaine, 5.8, very little heroin, hallucinogens, methamphetamine, and then prescription stimulants and opioids. So, in general, about half of people with serious mental illness are also having co-occurring substance use disorders. But in some ways, they could be using multiple, so it could actually be higher. But there's no question that marijuana is by far the most significant. I want to just also mention that behavioral addictions come into play. And I know a lot of people don't talk about this, but clinically, I have worked with many people that, come in with substance use disorders, mental illness, and at the same time, if you don't ask about it, they often don't say anything. But gambling, internet, food, sex, shopping, all of these things can also co-occur with schizophrenia, bipolar, and substance use disorders. We don't have a lot of really good data on this like we do from the National Survey on Drug Use and Health. But one of the things we've done recently with the New Mexico 5 Actions program is we have this assessment tool looking at symptoms. And we recently just did a brief analysis of about 50 people. And what you see here in this table is that up on the top right, if we go up there and we see for people who are positive for drugs, 81% were also positive for behavioral addictions. And if you look at alcohol, about 50% of people who had a problem with alcohol also had a problem with behavioral addictions. You can see the others in this table, and I will make sure that you guys get a copy of these slides. But the take-home message here is that co-occurring comorbidity is really the norm versus the exception. And I just want to make sure people recognize that behavioral addiction should be on the map as well. That's the one. We're good?
Looks good.
All right, I'll keep going. So just to kind of recap, I just put this slide in to show that there's a lot of common comorbidities for people that are struggling with serious mental illness. And the idea is that we really need individualized treatment, and we need good assessment up front so that we can look at these different issues when we're putting together our treatment plans and trying to determine where the leverage points are for intervention. So when we look at barriers to care, there's a variety of them. On the left is the most common for substance use disorders. People that believe they can handle it on their own, people not being ready to stop or cut down. There's no treatment available. People have transportation or childcare issues to make it into treatment. Cost, lack of insurance. They're worried about privacy, don't know how to access. Many of these are the same for schizophrenia and bipolar disorder. I think there's a little bit more stigma and shame, distrust towards the mental health system, also financial barriers, lack of culturally responsive care. All of these are barriers, but I think there is a couple that are even more important that I really want to talk about. And so hopefully some of you guys know about Xavier Amador. He is the developer of the LEAP program. We're going to talk a little bit about it, but he has a wonderful 18-minute TED Talk titled, "I Am Not Sick, I Don't Need Help." If you haven't seen it, it's wonderful. And he also has an extended presentation that he did for NAMI, I think down in Los Angeles. So if you haven't seen it, I really encourage you to look at it. Uh-oh, what is my red line through there? I tell you, today is
It happens sometime. Just keep going.
antidote. Just keep going, I guess. All right. So, part of it is that with both schizophrenia, bipolar, and substance use, there's this idea that people are in denial about their condition. So, what is denial? It's a statement that something is not true. So for people who are suffering with these conditions, for those of us who believe that they're in denial, then we do all kinds of things. We beg, we plead, we threaten, we lecture, we shame. We're doing all these things because they're our loved ones, and we know that they're hurting themselves because of their conditions and the substances that they use. And yet a variety of these different things in some ways don't get us very far. In fact, what happens is people put up additional barriers that make it harder to connect and to provide the care and the treatment that they need. So one of the things that we need to sort of move in a different direction is this term anosognosia, which I'm going to talk about in a minute for schizophrenia and bipolar. It also, I think, applies somewhat to substance use disorders. But for substance use, instead of denial, it's really about ambivalence. So let's talk about these terms. So on the left, when we think about schizophrenia and psychotic disorders, unawareness of illness is typically a symptom rather than a coping strategy. So again, this is about anosognosia. It is comparable to the lack of awareness of neurological deficits following brain damage. And this is in the DSM-5, but I believe this language came directly from Dr. Amador, and this is an incredible contribution. This idea, again, that part of the problem is people don't know that they have a problem. And so it's not denial at all. And we need to approach it in a different way. It's also the symptom that's the most common predictor of non-adherence to treatment. It's found to predict higher relapse rates, increased number of involuntary treatments, poor psychosocial functioning, and aggression and poor course of illness. At the same time, on the right, when we look at substance use disorders, the National Survey on Drug Use and Health goes out when they're doing their surveys, and they ask a bunch of questions. And when they determine that somebody has a substance use disorder, they follow that up with, would you like treatment? Or, are you interested in treatment? And if you look at this pie chart, almost 95% of people did not perceive a need for substance use treatment. So this is part of our challenge when we're thinking about, we have a very minority of people that are aware or believe they have a problem, but the majority don't have any interest in treatment. Now, instead of denial, I really think that part of what the research is moving towards is that it's about ambivalence. Ambivalence is sort of about this stuck point where most people on one hand believe that, maybe I drink too much, I've gotten a DUI, I've had some consequences, but on the other side of the equation is, I don't really have a problem, I can control my drinking. So there's this ambivalence, this stuck ambivalence. And I think, again, both of these combine to really challenge those of us who are caregivers trying to intervene. On one hand, people don't know that they have the delusions and hallucinations, that they have a problem. And on the other, they don't really think substances really is a big problem either. So this is challenging stuff. So I want to kind of focus on, how do we optimize the outcomes for what the caregiver needs as well as patients? And I'm not going to do a super deep dive into the treatments. This is going to be more at the 30,000 foot level so that people can kind of get a lay of the land. We can go into a deeper dive in terms of the questions. So what is it that caregivers really need? What's their toolbox of interventions? And on the right, I would suggest that one is really knowledge of these problems. Knowledge is power. So the more that you understand the nature of schizophrenia and bipolar and how these are spectrum and the different conditions, and also substance use disorders and addiction, that really helps out to say, okay, now that I really understand these problems, what do we know about the solutions? Second is accessing solutions and engaging with people really requires relational tools so that the interactions are positive, not those begging, pleading, threatening, that we utilize for denial, but what we want are positive interactions. And when people are ready, we want to be prepared to help them access treatment, or at least know how to do that. So we need tools for that. And lastly, and I think really, really critical, is that if you're a caregiver, doing so can be really, really exhausting. I've worked with a number of them in my private practice. And so managing self-care is incredibly important. So we'll look at these a little bit more detail. When it comes to understanding substance use disorders and addiction, this is going to be my sort of first shameless plug for the NM5 Actions program. We launched this in November of 2020. It is free to everybody in New Mexico. On the left is the homepage, and we're making some adjustments to that because in some ways we realize that the program doesn't necessarily require that somebody meets criteria for addiction. So that will be changed pretty quickly. It's more going to allow people to have kind of a discovery and looking at their use of substances. The website is at nm5actions.com. And there's over 100 short videos, educational. There's also content on there, and we'll talk a little bit about this in a bit, on CRAFT, which stands for the Community Reinforcement Family Training Approach, how to help a loved one. There's also tools to access treatment. So I think this is the important piece, that in this program, we have a page dedicated to how to access treatment. If those of you know Brian Cerna, he's got a video in there. It's not so easy to navigate the treatment system. So there's phone support. And again, we're trying to provide resources so that when somebody is ready to access treatment, this is specific to substance use disorders, but the treatment system is very similar, and the tools that are included will also work for mental health. It comes with phone support from 988, but I think the peer-to-peer warm line is an incredible resource that New Mexico has that people can use if they want to talk with people that have lived experience. We have screening tools. It's available 24/7 on mobile-friendly devices. And again, it's paid for by the state. So this is the program where I would say if you're trying to educate yourself about substance use disorders, this is the place to go because we have a tremendous amount of content to help people really understand how do substance use disorders start, how do they develop, and how do they continue in people, and what are the treatments. I also want to just let you know that we've been doing webinars also for the last 4 or 5 years, webinars like this one, and we have a bunch of them at 5actionswebinars.com. So we have one that is specific on addressing challenges with addiction. Most of these you can see are 40 to 50 minutes in length. We've got one on benefits to peer recovery support, also one here on navigating the behavioral health treatment system in New Mexico that was done by Brian Cerna, a great presentation on zero suicide by CAMS. So if you haven't seen these webinars, I really encourage you to check that out as well as another resource. I want to also just let you know about these clinical practice guidelines. I know this is a little bit outside of caregivers and families, but these are two very important guidelines that came out in 2020. On the left is the Royal Australian New Zealand College of Psychiatrists Clinical Practice Guidelines. This is one of the best documents I have ever seen. The graphics in this thing are unbelievable. But again, this is targeted to clinicians. I know you guys have access to a variety of great resources through NAMI, a lot of other self-help books. But I just wanted to let you all know these can be found on Google. You can Google these and download these. And they are the latest guidelines that go through all of the various treatments. So if you are prepared to want to take a deeper dive, you can do this. But I know I just add these because I wanted to think about this as adjunctive to all the other resources that probably are a lot more appropriate. But at least you have these in your back pocket if you want to go and look at these because they're pretty recent. So how do we engage with people that don't really want to be engaged, that don't know that they have a problem? So in the field, motivational interviewing is really kind of the standard these days for people who are resistant to change in substance use disorders and addictions. When it comes to schizophrenia and bipolar, this would be Dr. Amador's focus with his LEAP program. And these are two books that if you haven't seen those, highly suggest that you pick up both of these. Because his approach, LEAP stands for listen, empathize, agree, and partner. I think it's just fantastic. Now, I will say that his books are really directed to the general public. Motivational interviewing, again, is directed to clinicians. And so, I apologize kind of ahead of time, but there's a number of things in MI that I think filter into the LEAP program. And there are things that I think within MI are very, very approachable for people to integrate into their interactions with their loved ones. There's a few sections in this book. This is the 4th edition, and I will say it's the most parsimonious. I've gone through the other 3 editions, and they've really whittled everything down into kind of the bare essence. Also, Bill Miller, who wrote this, is in New Mexico. So this whole MI comes out of New Mexico. What are the differences? This is just kind of a quick table. What is connecting the dots between these two is that they're both empathy driven. They really are about collaboration over confrontation. They focus on autonomy in the patients that we're trying to interact with, and they're very effective in resistance to situations. I won't go through this entire table because, again, you'll get these slides. But what I want you to gain from this is that the LEAP program was really developed to work with people with serious mental illness, and motivational interviewing was really developed to help people with substance use disorders. We've already talked about anosognosia as a core concept for SMI and ambivalence for substance use disorders. But the various strategies, I think, are quite similar. So I wanted to just sort of put that table out there that you can look at it a little bit more in terms of how to compare and contrast these. I want to talk just briefly about motivational interviewing. It's a particular way of talking with people about change and growth to strengthen their own motivation and commitment to change. It's a way of accompanying people throughout the journey of change and growth. So you can see already at the high level that, in some ways it can be very appropriate to utilize within the serious mental illness population. But again, this was developed for clinicians. Here is really the whole focus of it. It's about how do I engage with somebody? And the key question is, can we walk together? Can we just start engaging in a helpful conversation? And then as we're talking together, what's the focus of this conversation going to be? Are we going to be talking about use of medications, your sleep, showing up on whatever that is? How do we focus together on what's important? And why should we go there? That's sort of the evoking piece of this. Why are we talking about this particular issue right now? And then how are we going to get there? What's the end point of having this conversation? Part of the MI approach is to be curious, being humble with a beginner's mind when we're talking with people about some of these issues that they're very resistant to even look at. And again, in some of these issues, they don't even know that they have a problem. We want to pay close attention to how people respond to us, particularly in these interactions. It is a dance. It's not a solo performance. We're engaging with somebody in a particular way. And we want to really think about how to respond in the moment. And I'll talk a little bit more about another approach that can help. I think this is really critical, though. Regulating our emotions when we're doing these interventions is so key. And I think what happens in my experience is that when our loved ones are in a crisis, our emotions go through the roof and these interactions are so painful. So learning to kind of manage emotions is not easy, but it is something that when we can calm the emotions, we are more effective at being able to help those we care about. This is an example of motivational interviewing for alcohol use. So the scenario is struggling with alcohol. I don't think that my drinking is a problem. I have a job. I only drink at night. So the approach, if we're doing reflective listening, would be, so you don't see your drinking as a problem because you're managing your responsibilities. Eliciting change talk. Have there been times when drinking caused issues for you, even if small ones? So we're trying to get, again, the person to talk a little bit more on the other side of the equation about kind of the consequences of drinking. Exploring ambivalence. On one hand, drinking helps you unwind. I get that. On the other, has it ever gotten in the way of things you care about? So we're talking straight to that ambivalence. And the way that we support autonomy, it's totally up to you what you do. But if you ever decide you want to make a change, what would that look like? Why does it work? We're helping the person explore their own reasons for change rather than being told what to do. It acknowledges the benefits they see in drinking, well, gently prompting kind of the reflection. And it also respects their autonomy. If we look at the LEAP program that Dr. Amador created, this is the website. There's a lot of wonderful resources, but you can see on the right that, again, I mentioned this earlier, the LEAP stands for listen, empathize, agree, and partner. And these also got these three other issues: delay, opinion, and apologize. It's similar, but in a little bit different way from MI. So what does this look like? An example with bipolar. The scenario is a person refuses to take their medication saying, I don't need meds. There's nothing wrong with me. You're just trying to control me. So the LEAP approach would be, okay, I hear you. You don't think the medication is necessary and you feel like others are trying to control you. We're listening. Empathize. That must be frustrating to feel like people are making decisions for you. And we agree. I don't like it when people make choices for me either. We all want to have control over our own lives. We partner by saying, I respect that you don't want to take medication. Can we talk about what does help you to feel at your best? Why does it work? It avoids the arguing about whether they have an illness. It builds trust, and it also focuses on collaboration. So I think you can see how there's an overlap between MI that was developed for substance use disorders and the LEAP that was developed for serious mental illness. I want to briefly talk about CRAFT. Maybe some of you are aware this was also developed in New Mexico by Bob Myers. And this was developed for people who are trying to engage a loved one in substance use treatment. You can see the subtitle there, Alternatives to Nagging, Pleading, and Threatening. Now, I will say that this is an online program that you can access for free in New Mexico through going on to the NM5 Actions program. There's a page dedicated to CRAFT, number of videos. Brian Cerna also has the Family Empowerment Project that you can access for free. But I love this approach. And I don't have time to go into a lot of detail, but there is a webinar on those 5 action webinars. Dominique Simone Levine, who developed this, has done a webinar and you can learn more about it. But again, this is a free resource to everybody in New Mexico, and it's one of these ways that you can approach people who are resistant to change. So lastly, I just want to talk about caregiver self-care. I know in my personal practice that I have worked with a number of people that operate in this caregiver sort of mode. And when I've done work with them, they're almost always overwhelmed. They have a very overactive, hypervigilant nervous system because they never know when they're going to get the next call, what the next challenge is going to be. And so part of that work, from my perspective, has been to help people understand that dealing with somebody that has a serious mental illness in some ways is sort of like continuous traumatic stress. And the best way to work on that is to recognize that it does change the nervous system, and that doing some trauma work and learning how to calm the nervous system down is one of the best things that a caregiver can do for themselves. And it actually makes them more productive and helpful when they are trying to help their loved ones. I've done a webinar in the past on grief and loss, and Francis Weller has a wonderful book called The Wild Edge of Sorrow. And one of the gateways of grief is that we expect something and we get something else. And so that piece, I think, can fit into the work of caregivers. Looking at, what is the meaning and purpose of my life beyond just being a caregiver? I know that for some people that I've worked with, it's their whole life. It's hard for them to separate out. They say, I can't do anything else. This is the one thing that I have to focus on. Fun, play, and pleasure go out the window. Basics often are really challenging. So, partly working on the spiritual development piece can be another way of incorporating self-care, a super important piece for those of us that are taking care of people that have schizophrenia, bipolar, and substance use disorders. So I want to talk just briefly about the patient. I'm not going to take as deeper dive, but what do people that are challenged need? Well, they need access to care, first of all, but they also need relational trust and connection with people that, again, are not trying to push them in a direction when they don't think they have a problem. They need expectations. We need people to say, okay, based on your expectation, here's some things that might help you. And there needs to be an alignment between those two. And also they need evidence-based treatments. One of the things we know that can help people the most is adherence to medication. When people are on medicines, they tend to do better. And so, a lot of times we'll talk about long-acting injectables as one way to enhance medication adherence. Wraparound services, and in the end, symptom reduction and enhanced quality of life. So one way that we sort of get to these outcomes, particularly the relational, aligned expectations, and evidence-based practices, is through what is known as the contextual model. I should have put the source on here. This is Bruce Wampold and Zach Immel. But what this really is saying is that when somebody enters into treatment, there's this initial therapeutic bond, and there are these three pathways that ultimately lead to the positive outcomes we care about. Better quality of life, symptom reduction. We've already talked about the importance of the real relationship, and that's using the LEAP program, that's incorporating some MI, particularly if you're a clinician. And the aligned expectations, I think, comes out of using those strategies of LEAP instead of really pushing against people's barriers and their idea that, look, I don't have a problem. We try to align expectations, find out what they are willing to do. And the interventions then are the third pathway. These are the evidence-based practices. Now, you might be wondering, what are these percentages? When you break down the variance in these outcomes, 70% of good outcomes is about the relationship. In fact, it's really everything. When I talk about, people ask me, what about referrals? How do I find a good therapist? I say, you know what? It's all about relationship. And in many ways, it's like reading a book from its cover. It's the most important variable. Expectations is 29%. So you might be wondering, wait a minute, the interventions is just less than 1%. What that means is that if pathways 1 and 2 are in place, we have a variety of interventions that work equally the same. We don't have one intervention that's better than all others. So what we really are looking at here is the variance between interventions. It's absolutely critical that there is an intervention, but you have to have pathways 1 and 2 for those interventions to lead to good outcomes. That's really the essence of good therapy. That's why I really wanted to take some time to kind of cover this contextual model. Only got a few more slides and we'll open up to questions. On the left here, this comes out of the NISDA, and it just breaks down and it shows that only about 25% of people are getting both substance use treatment and mental health treatment. This is what needs to go up. To optimize care, we really need to address all of those comorbidities as a package. And so how do we do that? Well, one is, I think you learn more about the 5 Actions program that helps with the substance use disorders. You guys, I think, already have some wonderful resources about treatments and how to intervene. And also you can look at those clinical guidelines if you want to take more of a technical, deeper dive. My last thing is I really, really would appreciate if people can sign up for this program. You know, it's funded by the state. And we need people to kind of sign up and use it. And we have a hard time reaching out to people to have that done. So if you haven't signed up, it only takes 3 or 4 minutes. You just go to the NM5 Actions site. You'll see a button there. You can see it on here, sign up on the top right. We have a couple other, but I would so appreciate if you signed up if you haven't already. And if you already have, see if you have 1 or 2 people that could do it. That is my shameless plug, but I would really appreciate it. And I think with that, questions and discussions, and I'm going to stop sharing. So,
Thanks.
Terry's got her hand raised already.
Fantastic. Well, let's take it over to Terry.
Terry.
I really appreciate you addressing the comorbidities. I think many of us who've dealt with mental illness in our families or our communities know that often substance abuse is self-medication.
Absolutely.
And my own familial experience over decades of multiple family members is that co-diagnosis treatment facilities, in my experience, have been at least years ago. It was kind of suggested to do that, whether you were primarily wanting to focus on mental illness or substance abuse, because insurance would pay for the substance abuse.
Yep.
And a lot of those facilities were essentially just rehab facilities and did not sufficiently address the mental health component. They might have a psychiatrist on call or even on staff at best. Where are we in trying to integrate the comorbidities that are so intertwined in this community?
Yeah, I mean, it's a great question, and you're absolutely right. In the past, we had bifurcated systems of substance use and mental health, and we would ping pong people back and forth. You know, when I started doing clinical work 25 years ago, I would have a pot of money for the substance use, and as soon as I used it up, I would switch over to mental health, and I would use that pot of money until I used it up, and I would switch. And it was crazy. I will say that over the last couple decades, that people really do acknowledge. In fact, we now call the field behavioral health. Partly because it encompasses substance use and addictions and mental health. I think we still have a bifurcated system where when you enter into the mental health system, people are much more aware of screening for substance use and addiction, but often clinicians that do mental health work will say, well, I don't really do substance use, so I'm going to farm that out. When I was doing some of this work, I would sort of engage with some of the treatment programs that did residential. And I remember a couple of those programs that were working at substance use saying, well, these clients had underlying trauma, but we don't do trauma. We'll work on the substance use, and we'll when they come out of residential, they'll have to find their trauma treatment elsewhere. And I thought, this is crazy. That's partly why they're in treatment, to work on that trauma. So I think we've made progress. I think we have a long ways to go. I think that for parents and people who are trying to navigate care, for the loved ones, that it's a challenging piecing pieces together, but we have better models, but we have a ways to go. I mean, that's the reality. And if we had more time, I could talk more about, what are the specific treatments, right? Like, do you do parallel, serial? There's these different models of how you work with it, but in general, we take care of the crises first. After the crises are taken care of, we drop in and kind of look at what needs to be addressed next. And so there is sort of an order of how we look at treatment.
Can I ask a quick follow-up question? I don't want to hog things, but
Sure.
At least in my own familial experience in trying to navigate this, part of the reason that you went to dual diagnosis treatment programs was because we didn't have real parity of care for mental health coverage. I would argue we still don't truly have that despite the laws. But am I right in assessing that was part of the issue?
I think it is. The other thing you just mentioned that I want to touch on is I don't like the word addiction. And what I like is the word adaptive. And when you think about, again, 50% of people, and a really high number using, marijuana, that in some ways there's an adaptive quality to it. It's doing something that we can say, oh, you're addicted, you have this problem, we need to intervene. But on the other hand, part of the way I work is to say, okay, your use of substances makes sense to me. I get it. That's part of that motivational interviewing. But there's these underlying drivers that perpetuate your use of substances that we have to identify. And if we can go in and address some of those underlying issues that are driving your substance use, we can slowly back that down by treating these underlying issues. So that's kind of the dance that needs to be played. But to your point, we have a ways to go. It is not a completely integrated system, and it needs to be integrated with primary care medicine as well. And that becomes another part of that leg. Greg. Yeah, Greg.
Oh,
Greg.
Thank you, John. Thank you for your presentation and for your work here in New Mexico. Your talk in the LEAP program focused on those with a serious mental illness like schizophrenia and bipolar. But what about those who deal with a moderate mental illness, moderate depression, moderate anxiety, moderate PTSD, and substance use disorder?
So you're talking about specifically in the program that I've developed?
Yes.
I would say that it's actually more aligned with that. When I created the program, there's not a lot of content in there specific to bipolar and schizophrenia. There is some on bipolar, and I will say that in the screening that we're doing, it's really important. I think we screen early on for depression using the PHQ-9, but part of what's important is that all depressions aren't equal, right? So it's on a spectrum, and the reason it's important is that we treat unipolar depression very different than mood spectrum. So that's why I think it's so important that when people come onto the platform and they do a screen for depression, if they're positive, the next thing we do is say, okay, now you need to assess for bipolarity. Again, because it's important that you get the right treatments. We also have a much greater emphasis in the program now on anxiety, on trauma, and we're going to continue to focus on that. So I would say, Craig, that's actually more of what's in that program. There's a lot more content on that we've added. And we probably need to, in the next iteration, add more for schizophrenia and bipolar. It's a good question. What else is on your mind? Jessica.
John, so I wasn't sure if I wanted you to do this, but I just went to the website to sign up, and I want to just make sure that I am signing up for the right thing. So could you go to the website and just briefly show people, like, okay, if I want help for free,
Yeah.
click. Okay.
Yeah, let's do that. Let me hang on one second here. I'll go there and I'll show you guys. It's a great thing. I meant to do that. And all right, so let me show you really quickly here. Here we go. Can you guys all see this?
No. Oh, yes. Now we can.
Now you can. Okay. So there's two parts to this. This is the external part of the site. And I think I showed you a graphic of this, and you can scroll down and kind of learn a little bit about the program. This is where you would sign up here. I've already signed up. So once I sign up, I can go to the login here, and you have an email and a password, which I've already done. So once you sign up, you'll get that, and you go right into the dashboard. And so this is the essence of the program here. On the left is sort of the menu. We have sort of these three initial steps where you can take this assessment tool. I will show you that briefly. If you take the assessment, you go in here, and we have these 5 different areas, kind of back to what you were talking about, Craig, in your question. Do we address these other issues? So here is relationships, really focusing on attachment in some ways. We go to the next one. and we have trauma. So we use kind of the PCL5 short form for trauma. Pretty quickly, we go into mood depression. This is the PHQ-9. This person has no depression. They're doing really well. Then we move into anxiety, the GAD-7, which is, these are all validated screening tools. So this person has some anxiety. And then we've split out kind of addictions into alcohol. So this is the Audit C. That's a validated tool for alcohol. For drugs, we use the DAS-10. And then the last one is behavioral addictions, which we sort of had to create because there's not a really good screening tool. So this person has some behavioral addictions, and then you hit submit. And what you get out of the screening tool is this bar graph across these different symptom areas. And this is the kind of what's the word I'm looking for? The scale of how to make sense of interpreting it. And so instead of having numbered scores, we simplified it. So if it's no to mild, that would be check this out if you're curious, that would be this. If you're mild to moderate, then we would encourage people to check this out. I didn't score that. But if you score positive, which would be moderate to severe, then this would be definitely check this out. So if you click on trauma, it'll take you right to the trauma module. And you can see here that now we've got assessing different types of trauma, get your ACE score, you can do PTSD. And then there's a variety of other tools that are listed under here for trauma. So that's one thing that I wanted to show. Let me go back to, let's see here. All right, I'm going to stop sharing for a second. You guys are still seeing that okay?
Yeah.
All right, I'll just go back here real quick and I don't know why it is continue. All right, there we go. So let me reshare here real quickly. All right, you guys can see this now again?
Yes.
All right. So that's the assessment tool. The personal roadmap tool is you've got these sort of different buckets. And so if you click on mental health here, you've got a variety of different topics that you can pick: mood, anxiety, spirituality, and you hit submit. And again, we have about, I don't know, 120 videos. And so different videos will come up that link with those different topics. Help for a loved one is something that I wanted to show. And there's two sort of pieces. One is learning about craft. And so you'll see here a brief description of Bob Myers, who created it in New Mexico. But there's these short videos about what is the nature of craft? How does it work? Here's Brian. And you can connect with the Family Empowerment Project as well as connect with Craft Online. And this is an online resource similar to the 5 Actions with videos, really, really helpful resources. Here's the page on accessing treatment. And again, Brian has a video on just the challenges. New Mexico utilizes Treatment Connection. So if you're not familiar with Treatment Connection, this kind of takes you right to a site where you can put in information. We help to kind of guide and say, make a list of programs and services. You can get recommendations for people. You can actually use the helpline, the warm line to get recommendations. And we list all of the federally funded programs from SAMHSA as well here. So this is kind of dedicated to help people knowing kind of a one-stop shop of where to get information. And then just briefly, if you look at how do you learn about addiction, these are all different videos. So if you go to development of addiction, these are all videos looking at, availability and initiation. How does the brain get hijacked? Reward-based learning, diagnosis, defining. Some of you might recognize Wayne Lindstrom. We have some about tribal communities. So essentially, this is the dashboard that people can navigate to get content. So any questions that anybody has before I stop sharing?
I do actually really quickly, coming to you guys from Arizona.
Yeah.
You mentioned ACEs earlier, so would you agree that if someone is taking the ACEs quiz, that they should do so in front of a mental health professional, a counselor, or something like that?
It's a good question. What motivates the question? Why do you ask it?
It was just, sorry, I had to unmute again.
Yeah.
You had mentioned it and it just kind of triggered a question that I had.
Yeah, there's a website called ACEs Too High. And so it's in the public domain. People can go on ACEs Too High and and score it. What I've tried to do is, I'll stop sharing here, is put screening tools that are in the public domain that they're already out on websites. And, I think a lot of people are familiar with the ACE score. There's actually a couple books on it where you can buy a book off the shelf and take the assessment and try to see where you're at on those 10 questions. The thing about the ACE score is that it's retrospective, right? It doesn't really help people to kind of know right now in the moment sort of what's happening. I think it's a useful tool, but in some ways, again, it's another piece of the puzzle that people can do if they're sort of looking at kind of what is the load in my early life and how am I trying to make sense of what my symptoms are today. So I think somebody put in the chat, it doesn't have to be done in front of a mental health professional.
Yeah, John, but I would think with just about any screening tool, a person ought to pay attention to how they're reacting and how they're feeling.
Yep.
And, reach out and get help if something triggers their trauma. And I think that's a place where the 988 or even the peer warm line can be very, very useful because there's always support there a phone call away if somebody gets in that situation.
Absolutely. And if you go on and beyond that simple assessment, if you go in and look at any of those, we have that right at the beginning, that these assessments, you might get triggered, you might get, kind of output that you might be really worried about. So here's the phone support. Please get a hold of us. We've tried to make that super clear, particularly around issues that are sensitive like trauma. Because we know that just taking some of these tools can actually trigger people and bring stuff up. So we definitely have that on the site where we warn people that even taking this stuff can trigger stuff.
Do we have any more questions?
Could you possibly just put the link to that site in the chat?
Yes.
Thanks.
That's a good idea. Let me see here.
I hear that. It sounds like we're going to get the slides or the PowerPoint, but it would be awesome. Thank you.
Absolutely. We'll get you. There we go. Did that work? www.nm5actions.com.
It sure did. Thank you.
I spelled
And
it
not
right.
only that, but that site has the link to the warm line and, of course, the New Mexico Crisis and Access line, which is sort of parallel to 988. But those are also referenced on that site. So,
Yes.
well, fantastic. Thank you very much for the presentation, Dr. Fitzgerald. Really, really some interesting and useful information. We look forward to just being in a world where the fact that people frequently are struggling with both these conditions gets a little bit more acknowledged and the quality of care improves so that, we get better outcomes. Thank you so much. And with that, I want to thank everybody. We have a talk again next month, and I'm really excited about that talk because